Hello, everyone. Thank you all for joining us today for ToxTime. My name is Carissa Little, and I am one of the account managers here at USDTL. Today's presentation topic is detecting illicit fentanyl in newborns. And presenting today, we have Dr. Joseph Jones, Chief Operating Officer here at USDTL. We also have Kiabeth Santos, our newborn team supervisor, who will be the moderator for today's event. We now welcome Dr. Joseph Jones.
Thank you, Carissa, and thank you everyone for attending this version of ToxTime. Let us get started. So today, we're here to talk about the detection of fentanyl in umbilical cord tissue for the purpose of identifying newborns that were prenatally exposed to fentanyl. So by now, we are all quite aware of the current opioid crisis. Well, this crisis is also being observed with our newborns. Over the past decade, we have seen an increased incidence of neonatal abstinence syndrome, or NAS. Now, one specific opioid that has received a lot of attention recently is fentanyl, which is a very, very potent opioid. So what exactly is fentanyl? So fentanyl is a synthetic opioid. That is a very important medication for the use of the control of pain and also used in anesthesia. Unfortunately, in the wrong hands, it can be very dangerous when used recreationally. We see it mixed with heroin and cocaine, and this is dangerous because it's 100 times stronger than morphine, 50 times stronger than heroin. So if the person preparing the illicit drugs, if they get their math wrong, it can cause a lot of trouble. Fentanyl is dangerous enough that the DEA issued a nationwide alert on fentanyl as a threat to health and public safety. This was back in 2015. They stated that drug incidents and overdoses related to fentanyl are occurring at an alarming rate throughout the United States and represent a significant threat to public health and safety. So based on all of the above information, USDTL several years ago started working on a method for the detection of fentanyl in umbilical cord, and we were not aware of that appearing in the literature prior to that. But why did we choose to test an umbilical cord? It has been our experience that umbilical cord tissue segments are a useful specimen type for newborn toxicology. The umbilical cord is available immediately following birth. Compared to meconium, this typically saves at least a day of turnaround time. Has a long window of detection. It's universally available. Many babies do not pass enough meconium or it's missed, and we are unable to complete our testing. The integrity of the chain of custody is much improved. For meconium tests, you have the collection over several days, several shifts, multiple collectors, putting it all together to send to the laboratory. Whereas with umbilical cord, it's one baby, one cord, one collector, one collection, in the cup it goes and off to the lab. So the integrity of the chain of custody and the identity of the specimen is vastly improved. Saves the staff a lot of time. Meconium is a multiple step collection. And so in an environment of tight staffing that most hospitals are experiencing right now, would you rather do 3 or 4 collections per case, or would you rather do 1 collection per case? And lastly, the analytes are uniformly distributed along the entire cord. In the absence of previous literature, a cutoff of 500 picograms per gram, which by the way is the same thing as 0.5 nanograms per gram, was selected based on what we have observed with other compounds similar to fentanyl that are found in umbilical cord. However, fentanyl is a useful anesthetic that is used in labor and delivery. So while we want to pick up illicit fentanyl use, we do not want the red flag cases where the hospital administered fentanyl during labor and delivery. We do not want the hospital staff or the hospital caseworkers especially in an environment of staffing shortages, wasting their limited resources investigating positive fentanyl results when the fentanyl was actually administered by the hospital. So the question here today is the current cutoff of 500 picograms per gram adequate for detecting illicit fentanyl use while excluding hospital-administered fentanyl? To answer this question, we reached out to our colleagues at the Charleston Area Medical Center in Charleston, West Virginia, and we designed a study to determine if the 500 cutoff was adequate. So we conducted a retrospective research study with a convenient sample of 64 infants. This happened to be a month's worth of specimens coming from that location. We coupled a chart review for fentanyl administration along with the tox results for the umbilical cord specimens that were referred to our laboratory for routine toxicology analysis. For those specimens, we analyzed them with both our screen method of ELISA, which is an immunoassay, and our confirmation method, which is liquid chromatography tandem mass spectrometry. Quickly, the initial method, we weigh 0.5 grams of the umbilical cord specimen. It's homogenized, centrifuged, evaporated, reconstituted in a buffer that comes with the immunoassay kit. And we plate it using 20 microliters, and we follow the instructions of the manufacturer. The validation experiments demonstrated acceptable within day and between day precision, and we also demonstrated 2 standard deviation separation between our controls and the cutoff. The LC-MS-MS confirmation method entailed preparing an accurately weighed aliquot of between 0.1 and 1 grams, fortifying with a deuterated internal standard for both fentanyl and norfentanyl. Again, it's homogenized, centrifuged, and evaporated, reconstituted in a pH 6 phosphate buffer, and then it is forwarded for a solid phase extraction method to purify the extract. The solid phase extraction procedure is a typical procedure that is used for alkaline compounds in biological specimens. Separations were achieved using a Phenomenex Synergy Polar RP column on an Agilent 1200 HPLC system, and a depiction of the solvent program is seen on the right. This table depicts the mass transitions that we monitor using our SciEx 5500 LC-MS-MS instrument. If you would like further information about the analytical method, it was recently published in the American Journal of Analytical Chemistry, which you may download free from our website. So out of the 64 cases, 2 were excluded because we could not conclusively verify the connection between the mother and the baby with the medical record. Out of those 62, 37 received fentanyl prior to delivery. Doses ranged from 6.7 up to 392 milligrams of fentanyl. The duration of the administration ranged from a half hour up to 80 hours. Out of this group of 62 specimens, we had 1 positive specimen, which would be a 1.6% positivity rate for this group of specimens. Interestingly, fentanyl was not administered to this case at the hospital. Some more specifics about this 1 positive case is that we had a strong positive response with the extract of the specimen. The cutoff had a B over B0, which is a ratio used in ELISA of 43%, and this patient was all the way down at 11% B over B0, which is a really, really strong result under this test system. In confirmation, we found 6,469 picograms of fentanyl and 5,241 picograms per gram of norfentanyl. So way above the cutoff. In addition to fentanyl, we found amphetamine and methamphetamine, cotinine, and codeine, morphine, hydromorphone, and 6-MAM. So this is evidence that there was prenatal exposure to methamphetamine, nicotine, and heroin. With the exception of the positive specimen that we previously reviewed, We did not observe any reportable fentanyl or norfentanyl in any of the other specimens. However, when we analyzed the immunoassay results, we did see some differences. Specifically, we saw that cases that received fentanyl prior to delivery, we had an observed B over B0 of 91.3%. And the mean B over B0 for cases that did not receive fentanyl was 98.2%. This difference using an independent samples t-test showed that this difference was statistically significant. However, all of these results are well removed from the average cutoff of 43%. Additionally, when we compared the results for the 37 cases that were administered fentanyl, we did see a dose response according to the total fentanyl given to the mother pre-delivery. And again, all of these results are well above the cutoff, whose average was 43%. So our conclusions from this study are that the cutoff of 500 picograms per gram did not identify hospital-administered fentanyl, and it did identify at least one illicit fentanyl case. This study provided evidence that the cutoff could be lowered, and so this is what we've been working on, and we are due to release a new lower cutoff on December the 6th. That new cutoff will be 200 picograms per gram. So what trends are we seeing here at USDTL? 12-month review of positive results revealed that we see more norfentanyl in our specimens than fentanyl. The median result for norfentanyl was 10,756 picograms per gram, whereas the median for fentanyl was only 4,029 picograms per gram. The vast majority of our fentanyl positive specimens contained both fentanyl and norfentanyl as expected, and also as expected when we compare those concentrations, there was a significant association between norfentanyl concentration and fentanyl concentration. USDTL launched this assay back in the fourth quarter of 2018, and we have seen a significant increase in the prevalence of fentanyl in umbilical cord over time. And we wondered what would it look like if we broke out the positivity rates according to the timeline of COVID. Separated out the prevalence rate starting in the second quarter of 2020 to date, and then 2020 quarter one to prior, and those two positivity rates almost doubled. Prior to COVID, we had a pos rate of 1.08%, and after COVID began, we started seeing fentanyl in the 2.06% range, and those two prevalence rates are statistically significant. In conclusion, umbilical cord is a suitable specimen type for newborn toxicology, primarily because of its universal availability and the built-in turnaround time advantage. The fentanyl cutoff of 500 picograms per gram appears to be appropriate because it did detect an illicit fentanyl case while not flagging hospital-administered fentanyl. And the research that was just presented provided us with evidence that we can even lower the cutoff a little bit. And beginning December the 6th of 2021, we will lower our cutoff to 200 picograms per gram. Lastly, maternal fentanyl use has risen during apparently the COVID situation. There could be other reasons, but we all know that COVID has been a prevalent factor in our environment over the past year. So we know that this is a lot of information, and we understand that substance abuse toxicology is complex and sometimes confusing. It's our goal to be a resource for you and your staff. As pioneers in the field of substance abuse toxicology, we host these educational events to help answer your questions and clarify differences in testing. I will pass you along to Kiabeth Santos at this time, our business development supervisor, to expand on some of our other educational resources. Kiabeth?
Thank you, Dr. Jones, for that great presentation today. It's definitely exciting, this new cutoff that we're about to launch. So as Dr. Jones mentioned, we offer ongoing educational support. With that, are you curious about how to collect the umbilical cord tissue specimen for drug testing? If so, we would like to offer you the opportunity to meet one-on-one with one of our representatives to go over a virtual collection in service. This opportunity is being extended to you if you're a client of USDTL or if you're not a client of USDTL. If you're interested, a member of our team will reach out to you directly to schedule training. Click yes, interested in the poll, and we will reach out to you with further information.
Like and subscribe to our channel to receive notifications about new videos.